Thank you very much, Max and Monica. It's a great pleasure to be here today. And I hope that I can come and join you next year. Now, I'm just trying to find my, I'm sharing my slides now, I hope. Here we go. Yeah, here we are. So I'm going to talk today about monkeypox, but it's not called that anymore. It's now called Mpox. So we have to try and transition to this new name, and about the viral emergence of Mpox. So I'm going to talk about some of the history, the virology, and move forward through some of these topics and end up at the end with vaccines and a little bit HIV. So the Mpox virus came out of Singapore, monkeys from Singapore that was sent to Denmark for experimentation. And this physician and researcher, Preben von Magnus, isolated this DNA virus from monkeys who got sick with a rash. The first human case was in a 9-month-old boy in 1970 in West Africa. And we now know that Mpox is divided into two major clades. Now, why did it arise? How come that we've seen so much of it? If you look along this timeline, okay, it was first discovered in 1958, but very few cases, as I said, did we see anything really from 1970 to about 1990. And one of the theories is that Mpox took the niche, the environmental niche that smallpox had before. As smallpox became eradicated, Mpox started to rise. And that is where we think there's been an increase in Mpox in West Africa, and now, of course, it's spilled out into the rest of the world. And you can see here, before 1990, it was endemic in some of these countries in West Africa, and it then started to spread more and more, and in particular in Nigeria. And outbreaks in Nigeria have suggested that perhaps sexual transmission may have occurred. Now, if you look along this bottom timeline from 1971 all to the current date, you can see in these states in Nigeria outbreaks in various cases in the states of Nigeria. And then suddenly in 2019, you can see that an adult male in the UK got it from traveling from Nigeria, and another in Singapore, and then more, as you can see, as the years go by, from 2019 till currently, there's been more and more transmission out of Africa into other countries. Now, what does Mpox look like? It's a double-stranded DNA virus with an envelope and a core and a core membrane. And this is the way it infects cells. It has two forms, one with an envelope, the EV, and one called the mature virion. And the mature virion gets into the cell by macropinocytosis, and the envelope form by fusion. They form new viruses, double DNA, and then you get replication within the cell. You can see it's all extranuclear. What about the animal reservoirs? Well, we don't know, but there are various thoughts of where this could be from. It's been found in various animals, including squirrels and rats, and these lovely little animals, the prairie dogs. And there was an outbreak in America in prairie dogs, which transmitted to humans at the beginning of the 2000s. Obviously, humans, as we know, and non-human primates are also infected. And the proposed transmission cycle is out of these rodents into monkeys, or directly into humans, and also from monkeys into humans, and humans infect each other. There's a genetic relationship of this virus, the Mpox virus, monkeypox virus. It belongs to the orthopox genus, and you can see it's closely related to smallpox, cowpox, vaccinia, and canary pox, and other pox viruses. You can see here it is there, and here are the other pox viruses, closely genetically related. And all right. I wish you'd have said that earlier. Let me just see what's happening here.
I was having trouble too. You may want to just put them in presentation mode and then use your page down to move.
Can you see it? Can you see it now?
Looks fine now.
Okay, let me just.
That's moving perfectly.
All right. Okay. Okay, so I'll just summarize quickly. Here's it, the monkeypox going with monkeys from Singapore to Europe. It been discovered because it caused rash and fever in these monkeys, and the first human case in West Africa in a 9-month-old boy in 1970. And here is the timeline from 1958, when monkeypox was first described, to 2020. And we believe that Mpox has filled the environmental niche that was left vacant by the eradication of smallpox. You can see that it's been increasing in West Africa before 1990 up until the present day, more and more cases, and that sexual transmission in Africa has now been described. And here is the other timeline in Nigeria, these cases in all the states, different states, 17 states, 9 states, 5 states of Nigeria, and then suddenly cases appearing and linked to travel to West Africa. And this linkage to travel initially started the cases that we saw around the world. And this is the structure. It has an outer envelope and an inner core, a double-stranded DNA virus. And here are the two forms, the mature virion, which enters the cell by macropinocytosis, and the form with an envelope. And here they are producing 2 strands of DNA, and it's all extranuclear. This happens. It's all in the cytoplasm. And as I say, the animal reservoir is unknown, but it's in squirrels and in rats, and these cute little creatures called prairie dogs, which led to an outbreak in the United States in around 2003. We do know it goes into primates, including humans. And this is a transmission cycle: rodents to monkeys, rodents to humans, humans to humans, and monkeys to humans. It's related, as I said, to smallpox, cowpox, vaccinia, and canary pox. And here is the clade evolution. There are 2 major clades: clade 1, which we see in the Congo Basin and Central Africa, and clade 2, and this is the important one for outside of Africa, and you can see this is in Nigeria, Cote d'Ivoire. And in the red here, this is the clade 2, and the variation of clade 2, it's 2B.1 here that we've seen in the Americas. And you can see here that the Nigeria clade, where most of this most monkeypox outside of Africa are derived from, has now evolved from 2A into 2B over a very short period of time. And you can see the evolution, the continuing evolution, as we do sequencing from here into clades 1 and 2, and then into the various different clades we found in India, Thailand, UK, USA, etc. Now, why is it important to know about the clades? It's because clade 2 is associated with milder disease, fewer deaths, and a limited human-to-human transmission, and less viremia. However, between clade 1 and clade 2, there's no difference in hospitalization rates. That may be related to the fact that there are very few hospitals and access to hospitals in these countries, and there's no difference in illness severity or pronounced rash as far as we know. Now, the rise of Mpox outside Africa, you can see here, May the 7th of 2022, and that's not very long ago, an initial case of imported Mpox in the UK from Nigeria. And then we started to see cases isolated with no link to Africa. So in other words, human-to-human transmission was occurring outside of Africa, and then suddenly it started to take off, especially in the gay and bisexual men who have sex with men in many European countries, and associated with large gatherings and sex on premises venues. And by July, a little time after the first cases, the WHO declared a multi-country outbreak to be a public health emergency of international concern. And up until last week, there have been over 82,000 cases in 110 countries. Here are the numbers: over 82,000 cases, 65 deaths. The death rate is very small. You can see here the darker colors is where you see more cases. We don't have much data out of a lot of Africa and parts of Eastern Europe, but we do have a lot of data from Europe, which you can see is in dark colors, from Latin America and from North America, where we've seen a lot of cases. And here is just a color map for Central and South America, and you can see that Brazil has reported more cases than other countries in Latin America thus far. Now, as I say, numbers are declining, and you can see here in the region of the Americas, in this blue here, you can see them going down, and week by week, actually since August onwards, really, the numbers of cases per week have been declining. And if you want to look at Latin America's decline in this column here in the green and yellow, you can see Chile, for example, a decline since June of 18%. I mean, a weekly change, sorry, since last week, 18%. Colombia's gone down by 2/3, etc. And Bolivia's almost seen no cases now in the last week. And you can see the total number of cases, the major countries being Brazil, followed by Colombia, Peru, and Mexico. Now, how does it spread? Well, Mpox spreads through close contact, including direct skin-to-skin contact, especially with the rash, the sores, or scabs. You can also contract it from objects that have been used by people who have had Mpox, like clothes or bed sheets or linens. Exposure to respiratory droplets or oral fluids can it probably be a way of it being exposed, but the exposure has to be prolonged and face-to-face. And you can also transmit it from a pregnant woman to the fetus. Now, sexual contact has been a driving force for the transmission of Mpox, and probably because a lot of lesions may not have been seen by a person around the genitalia, they may have been hidden away, and transmission occurred that way. Now, interestingly, if you look on the left here in the African region, most cases of Mpox, people do not know how they were transmitted when they see the cases. Close contact was 30%, and contact with animals in Africa is important. When you look at the global north, it's mainly sexual exposure, person to person, and then other. Contaminated materials, you can see very small. And obviously, being gay or bisexual, being HIV, having sexually transmitted diseases, or multiple sexual partners are all important risk factors. And I think we're now realizing that Mpox has been transmitted sexually for a long period of time, but it's just not been recorded well, and we need further studies. And I think that we've had case reports out of Africa, but I think we're quite certain now, having seen the epidemic in the global north, that it is transmitted sexually. What do the cases look like? Most of them, nearly 90%, are in men who have had sex with men. And really quite interesting, up to half, in our unit it's a third, are HIV positive. Health workers can get it from exposure, but some health workers may be HIV positive, some health workers may be MSM. Travel history was common initially, but it's not the commonest way. As I say, it's mainly sexual transmission and MSM. Very few people have died. Most of the people are in their mid-30s, and we've seen very few females infected with Mpox. And most commonly reported setting for transmission of Mpox is basically venues where people get together to have sex. And we've seen in the global north very few children infected. Out of these 27,000 WHO collected, it was less than 17. Now, how do you test for it? Well, you use nucleic acid amplification tests, a NAT, you are using PCR. And now the problem with this is just one point. You can use a generic NAT for orthopox viruses, but there are people who may be positive on this test because they've been exposed to another form of pox virus when they were younger. So it may come up positive, but there are specific tests for Mpox which are preferable. Also, be careful of false positives. If there's absolutely no epidemiological linkage of a person who has a test, think about that test could be false positive. Obviously, sequencing is very useful to determine clades and to understand epidemiology. The best material is skin lesion material, swabs, exudates, the roof of a lesion or crusts. You can use oropharyngeal swabs for high-risk contacts, but there's limited data to support the use of other sample types like blood or saliva. Now, what about sexual transmission? A little bit more here. Mpox DNA has been detected in semen up to day 11 after acute infection in men. We don't know if this is still infective virus. And we say to MSMs who had confirmed or highly probable diagnoses of Mpox to use condoms for up to 12 weeks after complete recovery, because we don't know about how much they could be still transmitting Mpox through the semen. Case definition, there are 4 so far: UK, CDC, European ECDC and WHO, but basically it depends on rash, fever, lymph nodes, other systemic issues like pain and headache, and also about the mucosal lesions. And they put in here that you could have single anal lesions to make the diagnosis. And the presentation, it's like a flu-like illness: chills, muscle pains, backache, headache, fatigue, fever. But the main thing is that you get skin lesions and you can have lymph nodes. And here's the common presentations, which you can see here: any rash, fever, headache, and genital rash, all very common. Here's some presentations from Africa, and you can see these lesions, widespread lesions, but you can also get lesions around the genitalia in Africa, on the limbs, and you can see this, these children who've got widespread skin lesions. And complications there: keratitis in the eye, staphylomas, staphylococcus infection, caseation and calcification of eye lesions, secondary dermatitis, and a lot of edema. These are things that can happen in patients in Africa who get Mpox. Now, we do know that the incubation period's around 5 to 21 days, but most people present between 6 and 13 days after the first contact. And it starts classically with an invasive phase, with a prodromal symptom of fever, chills, myalgia, and then you get an eruptive phase where the rash starts. Now, originally in the African outbreak in adults, it often spared the genitalia, but we've seen now that that's different in the epidemic we've seen in the global north. And there again, we saw more patients in Africa, in children and pregnant women. And we do know that this disease can be more severe in people living with HIV who are immunocompromised. And now, if you look at some of the current clinical presentation, the mean incubation period is less. It's about 8.5 days. We've lost this classic pattern of getting invasive phase followed by an eruptive phase. You can just go straight to lesions. And the lesions used to progress from one stage to another, and now we see them at all various stages, and more in the anal genital region, and more mucosal involvement. So it's really interesting how the African Mpox and the global North Mpox is quite different, and I'm sure you've seen that also in Latin America. About up to half of the cases have no prodrome. Some people get systemic symptoms after the skin lesions, and if you do get a prodrome, it takes up to 4 days to get skin lesions, and lymph nodes are quite common. So here we are, the invasive phase. All these people have reported, these are various studies: fever, headache, lethargy, pharyngitis. But you know, in the winter season with a lot of viral illnesses, this doesn't really distinguish Mpox from anything else, but the rash will. And here's the eruptive phase. Most people have less than 10 skin lesions, but solitary skin lesions, and this is really important, has been reported in about 10% of cases. And skin lesions appear with a distribution in keeping with the patient's sexual history. So if they have a lot of anal intercourse, you'll see more around the anus. You may see them around the penis and scrotum. And it takes up to 2 weeks for the lesions to heal. And here are various lesions here in the genitalia. And you can see now some perianal lesions and solitary lesion, 2 lesions, sorry, here, multiple lesions there and there. So anal genital lesions are very common. It's important if somebody comes in and thinks they might have monkeypox to make sure there's a thorough genital and anal examination. And here's the classic evolution from small lesions appearing, then they're crusting over and scabbing, and the scabs then fall off after about 2 weeks. Here's the progression of anal genital lesions here, but this one has formed a large perianal ulcer after about a week. And here are some penile lesions which have formed a large penile ulcer. So they don't always heal up, as the textbook says. They sometimes coalesce and form large, painful ulceration. Here's some on the limbs. You can see this lesion here starting to become dry and crusty, and then the scab falls off. And many, you can see series, people have described skin lesions on the limbs and on the face and on the neck. And I remember a patient coming with one on the forehead. It was his only lesion until we examined his perianal area, and he had some there. So it's really a disease you have to examine the patient very carefully. Now, what about complications? Up to a third of patients can get quite bad complications, especially with proctitis, bad tonsillitis, and they may need antibiotic treatment for cellulitis or abscesses. Penile edema can be quite severe, and that's been reported in over 10% of cases. Mucosal involvement, sometimes with difficulty swallowing or severe rectal pain, is frequent, and proctitis as a single clinical manifestation of Mpox has been reported. Thankfully, encephalitis with this virus is very rare. Here we can see some oral lesions, and some of them progressing to large ulcers, making swallowing difficult. And here's some perianal lesions and rectal lesions. Again, lots of people have now published about these lesions. Management of complications, well, if you're septic, antibiotics. Bronchopneumonia, people have given empirical acyclovir and oxygen therapy, but I think we've come on to more definitive therapy in a minute. Secondary bacterial infection needs antibiotics and skincare. Encephalitis, of course, is serious. Pregnant women can miscarry, and you can get gastroenteritis, and keratitis can be quite severe. Mpox can mimic other STIs in its presentation, and many people who present with anal ulceration, people are tested for HSV and syphilis. Of course, they should be, but you should consider Mpox. But it's really interesting that sexual health screening was only offered to 33%. Sexual health screening was routinely offered, and 33% of them had an STI as well as Mpox. So not only Mpox you can get, but you can also have various other STIs. Now, what about HIV? Well, up to half of the patients with Mpox have been diagnosed in people living with HIV. In our unit of over 850 cases, 33% are people living with HIV. Most of these patients are on effective antiviral therapy, and less than 3% have got CD4 cell counts of less than 200. The illness duration, the clinical severity, hospitalization is not increased. It appears it's not increased in immunocompetent people. So if you've got a good CD4 count and your viral load's below detectable, your infection behaves like everybody else's. But those with advanced CD4 infection and low CD4, they may be at risk for more severe disease. We don't know what role HIV plays in shaping local immune suppression. We don't know much about any synergism between HIV and Mpox and severe presentations. We've seen it, but we don't quite understand how that might work. And also, we know very little about antibody responses and the length of immunity conferred by vaccines. Here's some data that we produced from HIV patients in Europe. You can see nearly 1,000 cases, but only 53 hospitalized and only 1 death, 1 in 1,000 deaths. The CDC have said that Mpox is, they've identified more amongst Black and Hispanic persons. They're disproportionately affected, but they're also disproportionately affected by HIV, and that may be the relationship. And there's been lots of studies looking now at Mpox and HIV status, and really the bottom line is it appears that if you're immune suppressed, you may be at risk of a more severe outcome. And here's some data from the CDC regarding Mpox in people who have HIV. They had 38% of their cases were HIV positive, and 8% of people with HIV were hospitalized, compared with 3% without HIV, suggesting a more severe effect in some of them, and they're more likely to have rectal pain and other rectal manifestations. And STIs are common. Now, what about therapy? Well, we've had 3 drugs approved for smallpox virus and 2 vaccines for smallpox virus, and these have also been sort of approved based on the fact that we wouldn't be able to have time to do trials of these, and so they're based on appropriate animal trials. So here we go. The major drug is tecovirimat, and that's been authorized, but we can use cidofovir, brincidofovir, which is an analog of cidofovir, and variola immune globulin. And there are some other drugs that people are looking at, antiviral drugs for Mpox, and it was really interesting. HPMA is one of those, and so is ribavirin. Here's tecovirimat. It's been approved for smallpox since 2018, and then is now used in Mpox, and it targets this VP37 for the development of intracellular mature virus. And it's broadly active against all the orthopox viridae. Now, there's very little published human experience, but most of it has been in treatment of severe or disseminated vaccinia virus infection. And there's a randomized trial going on by the ACTG now in Mpox, and other trials being performed in Europe. Now, it's given as 3 200 milligram capsules twice a day for 14 days. It's got very rare adverse reactions, headache, nausea, etc. And if you give it intravenously, it can cause infusion site pain, but it's usually given orally. And you shouldn't give it to people with severe renal impairment. If you look at this placebo versus tecovirimat, the number of adverse events are relatively the same. So it's a relatively benign drug in terms of adverse events. For HIV patients, the only real important drug interaction is with rilpivirine. So you may have to increase rilpivirine to 50 milligrams, and people who are giving long-acting cabotegravir and rilpivirine, again, you may have to give them 25 milligrams extra every day during co-administration. Cidofovir and brincidofovir also might be used. They're obviously given intravenously, and a lot of us who have lived through the HIV epidemic know about the nephrotoxicity. Vaccinia immunoglobulin could be used, and it has been used in patients who've had severe problems after smallpox vaccination, who are severely immune suppressed. But the CDC have said, really, we should give these drugs, especially tecovirimat, to people with severe disease who might be at risk of severe disease, and that's patients mainly with immunocompromised, pregnant women, and young children. If you've got complications like severe ulceration or pain or difficulty in swallowing again, that would be an indication to be treated. And finally, there are 2 vaccines that can be used to prevent smallpox, and they're used to prevent Mpox. One is a replication competent live virus vaccine, which we don't advise to use, and the other is a replication defective live virus vaccine, which most of us have been using. And you can see here in the replication competent, you can get auto-inoculation, you can get serious side effects and myopericarditis, whereas the replication deficient is pretty safe overall. And here's a horrible picture of a child who's been given the live replicative one who had eczema, and you can see that it's spread throughout the eczema. So it is a big problem using this live replicative virus. The guidelines are to give post-exposure prophylaxis to someone who's been in contact with known monkeypox. If you might be in presumed exposure and you're a gay man or other risks, you could have it, and you can also use pre-exposure prophylaxis, and this is what we've been doing mainly in Europe, and I know that you've been doing the same in the States and in Canada. We've been giving it to people who are at high risk, and most of those people are those who have been on PrEP, but we've opened this up to sexually active gay men, even if they're not on PrEP, and there are HIV patients as well. As long as they're immunocompetent, we've been giving them pre-exposure prophylaxis with the Jynneos vaccine. Vaccines should be given if you are exposed within 4 days, but up to 14 days. Mass vaccination for the general public isn't really being given. We have been sparing vaccine because you can give 0.1 of a ml intradermal. The problem is that once you've opened the vial, you have to use it all up. So it's good to have a vaccine clinic with lots of people coming so that you can give 0.1 ml intradermally. And here is the schedule: 0.5 ml subcutaneous or IM, or 1.1 ml intradermally. And then we're giving this to our HIV negative patients who are on PrEP or at high risk, and also all our patients with HIV. A second dose we're giving after 28 days. And with that, it's a rush through the whole Mpox. There's still a lot to discuss, but as you can see, the cases are declining. We're seeing less and less of it, and it may be an epidemic that's come and gone. But one thing I would say to you is that we must make sure that all the progress we've made in the global north, in Latin America, in other countries where the resources are, that we should make sure that this gets transferred to West Africa, and we can try and eradicate Mpox from the globe. And with that, I'd like to thank you all very much indeed.